And I was shocked when I didn't see that. I said, wait a minute. Clinicians are supposed to be data-driven. If you show them data, they will react, they will respond, and they will, of course, want to do the right thing.
Welcome to Series 3 of the Future Health Podcast, a podcast on the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry. We have an incredible lineup of guests this series, and we look forward to sharing it with you soon. Feel free to like, share, and subscribe so you don't miss a thing. Hello everyone, welcome to Future Health Podcast. Our guest today is Dr Raj Behal. He's currently the Chief Quality Officer at One Medical, and he was previously Chief Quality Officer, Associate Dean of Quality, and Clinical Professor of Medicine at Stanford. He has a strong passion for data-driven improvement of health outcomes, and I'm really interested to learn more about this within the context of future health and what it means for New South Wales Health. Welcome, Raj. So glad you are here to join us today. I was hoping you could please introduce yourself to our listeners and give us a bit more background as to who you are and what you do.
Yeah, absolutely happy to. And Sarisha, thank you for having me. And I'm really looking forward to the conversation. So as part of my introduction, I think of myself as a doctor. I'm a medical doctor, internal medicine doc, trained in public health and in clinical informatics. And I've been practicing medicine for about 20 years, mostly in academic university teaching hospital settings in the US, and really taking care of sick, complicated patients in ICUs and patients who are waiting to get a liver transplant or have had a liver transplant. And I'll talk more about how did I get into this field as a primary care doctor, as a GP, essentially. So just backing up a little, when I was in medical school, I became really interested in computers in medicine. And keep in mind, this was in mid to late 90s. So I'm dating myself here a bit. The hospital I was training in just had implemented computerized order entry systems. So this is early days of electronic health records. So I had a chance to work on some of the systems to look at list of medications and make sure the right medications are on the list that the ordering doctors will see. So fairly trivial, almost clerical task, but I was so excited to do it. For two reasons. One was it was really interesting to work on something new, a new technology. And the second was that it paid about $50 an hour. So in those days, as a medical student, if you could get any dollars any place, that was super exciting. So working on that really gave me this sense for potential future of computers in medicine. And I said, when I grow up after my residency, I would love to get some more training in informatics. So fast forward, I finished my residency in internal medicine, and then I applied to a number of fellowships and fortunate to get accepted in one. This was the Harvard MIT Healthcare Informatics Fellowship. So as part of the fellowship, I was also offered a spot in the School of Public Health. So given that it was fully covered, I said, why not? So I started my fellowship training and my master's in public health at the same time. So I'm learning about topics like clinical effectiveness. How do you design quality measures? How do you look at quality? And how do you manage and monitor patient safety? And these were early days of patient safety. So there were some of the leading experts were around me. So I had a chance to learn from them. So as I was getting my fellowship training, I was working on large data sets derived from the local electronic health record system, and I was applying what we call today machine learning and AI algorithms. Now, back in the day, it wasn't as cool or as hip as machine learning is today. For me, these were simply some tools I was using to understand data and patterns and find things and opportunities that we could focus on to improve healthcare. And in my public health classes, I was learning, how do you design measures? How do you actually go out in the field and apply those measures to understand what is actually, or the quality of care that's being delivered? So after I finished my training, I looked at myself and said, okay, you're a doctor, a medical doctor, with training in public health, clinical effectiveness, and in clinical informatics. What do you do with this? And at the time, there weren't chief quality officers or medical directors of quality. Quality wasn't mainstream. Patient safety was just about coming out. So again, I was fortunate to find a role with a consortium of teaching hospitals. So these were teaching hospitals that all grouped together and decided to benchmark cost, quality with each other. So I started working with this group, and the first job responsibility was to build these risk adjustment models. So here's my training in informatics and machine learning. So I built models on cost and mortality and length of stay so the hospitals could benchmark. And I'll come back to this story because there's really some career-defining moments here for me. The question that was really driving me at this point was, why do people die in hospitals? And when I posed this question to some of my colleagues, the first response was, the question doesn't make sense. Raj, everybody dies, and some people will just die in hospitals. So what is it that you want to look at? And I didn't really have a clearly defined question. It was more an academic curiosity that actually became a turning point in my career. And I'll come back to that. So after working with this consortium, I joined a university hospital in Chicago as a patient safety officer and started to work on, adverse events, patient harm, complications, mortality, program outcomes. Did that for about 7 years, and then I was recruited to Stanford to be the chief quality officer there, really working on the same type of issues, better health. And at the same time, there was a movement in the US towards value-based care. So how do we do the right things, improve health and quality as we lower cost of care? So I spent a good 5 or 7 years working on health outcomes and at the same time, value-based care or cost of care. So I was able to use my skills in data science, machine learning, and public health and quality improvement in these settings. And and let me come back to my clinical work as well. So I was initially seeing patients in general medicine, primary care clinics. I developed an interest in abdominal transplant patients, partly when I was training and then when I was at Rush in Chicago. So over years, I modified my practice. So I was focused much more on these patients who needed, I always like to say, everybody needs a good internist. So I wanted to be that good internist, internal medicine doctor for these patients. While everybody else was focused on the kidney or the liver, I wanted to take care of the whole patient. So that was part of my interest that ties to my public health training. So as I was working on these initiatives and taking care of these complex patients, it became really clear to me that I wanted to focus and dedicate my career to making an impact as a doctor, but then also finding ways to scale that impact. So sort of the public health doc in me is thinking about, well, how do we help more people and more patients with this science? So let me pause here. It's a long introduction, but I'm happy to elaborate on any of this.
Look, absolutely. Look, and I think you as you were talking, I two things came to mind, like two things I picked up. And one there was when you said you didn't want to really just specialize. You wanted to you wanted to help the whole patient, I suppose, which comes back to a big part of what we here in New South Wales want to do, which is, the holistic care of a patient. And, we've talked for years about challenges in medicine where everyone wants to specialize and subspecialize, but there's very few. The term we use here is generalist physicians, which, and number two, when you talked about scaling up, because we work in a very broad context where there's different population groups and different elements within healthcare that operate slightly differently, and everyone tries something. But these pilot programs are often very challenging to scale up. So I would love to hear more about, what areas you were successfully able to scale up and what drove your interest in that further, and what you did to address some of those challenges.
Yeah, that's a fascinating question, and we could probably spend the whole hour talking about that. Maybe I'll tell a short story which really galvanized my interest and passion in this work. So when I was working with this consortium of hospitals, and I mentioned I was building these risk adjustment models, so hospitals and clinicians within those hospitals could look at data which was at least risk adjusted. So a bit of apples to apples comparisons. So after I put those data out and shared it with the member hospitals, I thought I could just sit back and watch improvement happen. And I was still a young lad early in my career, and I was shocked when I didn't see that. I said, wait a minute, clinicians are supposed to be data-driven. If you show them data, they will react, they will respond, and they will, of course, want to do the right thing. And I was looking at one particular hospital that was at the bottom of the list. They were ranked last in hospital mortality rates. So after watching them stay stuck in that spot, I picked up the phone and called the CEO of the hospital, whom I'd gotten to know in other settings. So I said, well, I've been looking at the data, looking at the list, and your hospital really hasn't moved much. What is going on? And he said, well, what do you think is going on? I said, well, I have no idea. Please enlighten me. So he said, well, we shared the data with our department heads, our chairs, and our clinicians. Nobody believes in the data. They don't think there's a problem. If there is a problem, it's in the data. So I said, I spent a lot of time building these models, so it sort of hurts my pride when I hear that. So I said, do you mind if I come in and speak to these department chairs? And these are, prominent physicians. But in my sort of early days, I said, well, how hard could this be? I'll come in, I'll talk to your clinicians, I'll talk to the frontline staff, and see what is actually going on, and if I can help them understand data better. To make a really long story somewhat short, I did go on site, and I looked at the data to identify, are there certain areas that have higher than predicted mortality rates? And one of those areas was neurosurgery. So I made some appointments to see most of the chairs, including the chair of neurosurgery. So I'm in his office with my colleague who's a retired critical care nurse. So the two of us are sitting waiting for him to show up to this appointment. And he finally comes about half an hour late. And he wanted to know who we were and what we were doing there. So we answered a few questions. They provided some context. And then I shared a piece of paper with him. And so here's some of the data we've been looking at. And this shows the mortality in your program is about 25% higher than predicted. So he starts to look at the piece of paper, looks at me and looks back at the paper, and I can see his cheeks are getting flushed. And he's getting upset. And he started pounding his fist on the table and said, do you know who I am? I simply repeated his name. I thought maybe I'm in the wrong office. which turned out to be not the right thing to do. It just made him more angry. And he said, look, the surgical procedure you've listed here, do you know who developed that? And I really honestly had no idea. So I said, I have no idea. And he said, I did. And he said, here you are showing me this piece of paper and saying the data tells me the quality of care that I deliver is poor. So I was a bit taken aback, not the response I expected. So I had to do a bit of backtracking. It's my first conversation with a senior, prominent clinician, a leader in his field, and I've upset him. So I said, look, I'm not saying the quality of care you're providing is bad. All I'm saying is when we look at these numbers, they tell a story. And everybody else, by the way, it's an open benchmarking database, so your colleagues can look at this and draw conclusions. So if these are not right, there's something that's making them wrong. That's all I'm saying. That the number is 125, which is 25% higher than predicted. He said it's all garbage, it's all data. And by the way, we take care of really sick patients, and there's no amount of risk adjustment that can capture that. And I actually understood that. So anyway, he left the office really upset, stormed out. And so we sort of took that with a grain of salt and said, well, let's continue to meet other clinicians. But I'm really afraid now going into these other meetings. But most of the other meetings went fine. They were okay. And as we finished the day, we're walking out the hospital and we see this chair of neurosurgery notice us, then walks rapidly towards us. And my colleague, elbows me and said, Raj, you're about to get punched. So I'm quite afraid for my life here. And he comes, stops me, and he said, you're the two that I spoke with, right? And I said, yes. And I braced myself. But I was really surprised. He extended his hand and he said, let me thank you for being graceful under fire. He said, I see your point. I still think it's coding issue, documentation issue, it's a data problem, but I think you're right that if this is how my care is perceived, then whatever the problem is, we should try to fix it. And then he quickly walked away. So the lesson I took from this is that data, even if they're imperfect, and I would say especially if they're imperfect, can be a really useful tool to open the door, have a conversation, even if it's a difficult conversation. So long story short, I finished the assessment, looked at their systems, processes, and made several recommendations that weren't about individual clinicians. It was for the systems and processes. To their credit, they addressed all of those issues. Then about 6 months, we looked back at the data, and they're almost as predicted. So all of the excess mortality we had noticed had disappeared. So, and we ended up presenting this data nationally, and actually even in Australia in probably early 2000s. And I started to get a lot of interest from other teaching hospitals that can you come and do the assessment and work with us. So I ended up working with about 50 teaching hospitals, starting with data, having a conversation, understanding the problem, looking at systems, processes, making recommendations based on best practices, evidence. And to their credit, most of them improved. Because, Suresh, I'm in a roundabout way coming back to your question. So I said, this is how I have an impact that's more than a single patient and a single hospital. I can be that catalyst, someone who's looking at data and helping these hospitals share best practices and solve problems that are specific to their system. When they do that, literally several hundred fewer patients died in these hospitals. So I give the credit to the local teams, the clinicians who actually did the hard work and made the improvements. But it didn't take me long to sort of think about all of this work as public health and scale. So you can start with data, understand the problem, share best practices. That's how we scale. Not rocket science, but when implemented, executed in the right setting, it can be quite powerful.
Oh, absolutely. And I think as I was listening to your story there, which did make me chuckle, I found it interesting, and I'd love to delve into some of that a little bit more, because you're a clinician who's building these models to then, show your colleagues essentially. And there's still an element of mistrust. So, I mean, I think, one of the struggles we have in our system is when something is not designed by clinicians. And there's always a bit of mistrust as to, well, it's some random company that's designed this model. And so, the story's not accurate. But you yourself as a clinician were someone who, and it sounds like you self-taught yourself how to do this, design this model. How difficult is it to get through to your own colleagues? Like, is it harder because you're an insider, or is it easier in some ways because they eventually learn to trust you as a fellow clinician versus, a consultant off the streets who's come in to design this?
Yeah, really interesting question. And it took me some time after stumbling several times to realize that they weren't actually objecting to the data or to the risk models. You really had to peel the layers of the onion and see what is it that they're pushing back on. In many cases, I found that there was already some distrust, either with the hospital, the administration, or even with the quality team. They wanted to understand, why are you looking at this? And what would you do with these data? So that, once I realized that, I actually relaxed a lot. Because I spent a lot of time, I would bring the data with me, but I would set that aside and just have a conversation, set the context, what we're doing, why we're doing it. And I do that in my own practice, the hospitals that I worked in, because it was now my job. I couldn't make recommendations and walk away. I had to actually implement those things. But this is a really important lesson that's often overlooked, that we think the pushback is to the data, is often to something else. And we have to spend time thinking about what is that something else that people are reacting to. And once you address that, people will embrace clinicians will embrace even imperfect data. So in many cases, I've started that conversation by acknowledging, look, what I'm about to show you is possibly wrong and at least off the mark. But I want to start a conversation around what we do, how we do things, and if there's any room for making improvements in how we care for our patients. And that conversation goes much farther than starting with saying the mortality rate is high or infection rates are high. I haven't seen that work that well. And interestingly, most of the hospitals I was in, trying to help them, they'd all gone through this process. They've had their staff meetings and shown data. But when I asked them, well, have you sat down with such and such and had a conversation? They said, well, we share the data. What's the conversation? Why do we need another conversation? So I think it's all about building trust and trusting relationships and making sure the intent is clear. And after that, give people a chance to modify how we're looking at data. Even though I learned the science of building these measures, often I would be sloppy in building the measures and let them tell me that if you're looking at bone marrow transplant or pneumonia or heart failure or heart transplant, that these things are important to factor in, or you should break the data this way. And then the metric makes more sense. So say, great idea, great insight. Let's do that. So now they have some ownership. They help me design it. And that process goes much better because now I end up with much better data and much better insights. So anyway, I think the data are necessary but not sufficient.
Yeah, and I think what you've mentioned there about a sort of collaborative effort, and when they then own the data, it makes it much more palatable to have the conversation because now it's their data versus something that you're providing them. You kind of like just listen to your story about how you got into this. It almost sounds like you fell into it by accident. You know, you sort of were there doing one thing, but you found an interest. Given how important this is going to be, because this is a podcast about, future health and the future of work, given how important this is going to be and to have clinicians like you who are interested, who understand patient, measures and data, to be able to have conversations like that in the future, what do you think is a good way to attract more clinicians into this area, not just to have conversations about data, but to be the ones to design these data models themselves?
Yeah, it's the simple answer is training programs, which I think are useful. For many, it poses a bit of a burden to take a class, to take a course, and learn the mechanics of something. What I found useful working with actually a lot of the junior faculty and junior residents. If they have an interest, and the interest may be in research, they want to publish, write papers, say, okay, work with me, we'll share data, and you will look at data, you will try to solve or understand the problem that you're trying to solve or understand using the data. And we're here to help you, whether it's the quality team or the data science team, we're here to help you understand what this is actually telling you. So having people go through the process, essentially the process I went through, learning by doing and stumbling, picking up, getting input from other experts. For me, that's a much better model of developing the next generation of clinicians who not only understand what the data are telling them, but also what to do with that. So an experiential approach rather than a formal training coursework, at least in my experience, is the better way to go.
Yeah, and I think so because the difference, I suppose, here in Australia to some extent and in New South Wales is a lot of the care on the ground is nurse led, where our teams are predominantly led by, the leadership team is predominantly our nursing staff. And so there's sometimes a disconnect between the data of medical clinicians versus on the ground data that, nurses collect with their experience. So I think, something like a flat training program may not be the solution. So do you think there are, on the ground, at the coalface programs of learning that can be developed, which are, shorter, or is it just finding the time day to day, in addition to providing patient care, to be able to do a bit of better understanding and deeper understanding of patient data?
Yeah, I think some of this could be embedded in nurse training programs, residency training programs as electives, that you can engage in these projects with data and understanding and the improvement methodology. There are, of course, many online courses available, and I've had many colleagues take those courses as background. So if you want to understand the mechanics behind a machine learning algorithm, that's kind of hard to teach someone one-on-one. It's better if you have some background in the mathematics behind it, which you could do from many of these online courses. But it's really the hands-on work, I think it's likely different in every healthcare system and setting. Where do you find those opportunities? Where do you find the time? How do you embed this work in day-to-day so it doesn't appear as not only do I need to take care of my patients, now I have to do this project or take this course. So one approach is, learning from the lean approach is to think about some of these key problems and the related metrics. In the systems I've been in, we would put those on a board in every unit. So people can look at what the rates are. It could be an infection rate, or it could be fall rate, it could be medication errors, but simply putting those data up for people to see and reflect on in their day-to-day, at least gets people thinking about it. And then providing some guidance on what this means and how do you do a root cause analysis on the fly within your staff meeting. These are subtle ways that you can pull this type of knowledge and know-how into the day-to-day workflows. There's not a simple answer to this, right? It's either a pedagogical solution, coursework, or embedded in day-to-day, or giving people time to go spend some time, protected time, with other experts and come back and teach your colleagues.
Yeah, I think you're right. It's probably a blended approach because, for New South Wales Health perspective, we do have a patient-reported measures portal which collects the sort of data around, patient outcomes. And obviously, in our system, it's very much a multidisciplinary team where you've got your nurse, you've got your, allied health, the physiotherapist or the occupational therapist, your assistants, and so it's a very much a when they have the huddles and things. It's very much a collaborative, team-based model that we try and implement. So I think you're absolutely right. Those are probably the places to have the conversations around data. And that way you get the perspectives of the whole team versus it becoming medical driven or nursing driven. Because I think and I don't know if it's the same challenge in the US, and maybe you can elaborate a little, but we find sometimes with those discipline silos, nurses may only be interested in this particular data set, whereas the medical profession probably only looks at surgery, outcomes in that context. But when you put the data together, it might tell a different story.
Yeah, I think that is a best practice to look at these problems with a cross-functional team, right? Essentially, the system, we used to say the system should be around the table when you're looking at a case or looking at a metric that's problematic. Now, I spent a lot of time talking to groups individually. If there's an issue in pediatric ICU, I met with the night nurses coming in the evening to meet with all of them, because otherwise, if you simply look at the daytime problems, you miss the whole other aspect of a healthcare system, which is radically different at night. My point is that until you get insights from the field, either it's a person going out to get those insights and then synthesizing it, or you bring those individuals together. And ideally, if you can do that, piggyback on things that already happen, meetings that already happen. Maybe if it's a staff meeting, you take the last 20 minutes or the first 20 minutes thinking about it or looking at a patient safety issues. There are a lot of hospitals that have done things like this that tend to be successful, but I would add that only if it sort of fits their culture and the context. So to some extent, the solutions may differ locally, but the general approach that I've seen work is that you get the multidisciplinary input into the problem. You set aside any blame, because as soon as people start thinking about this this will have consequences for them or for their colleagues, people back out. And this is where I found personal conversations really helpful so people can speak freely.
Yeah. Taking a little step back, because you talked previously a little bit about, algorithms that underpin these models, which then tell a story about data. And I know it's not your area of expertise, but obviously one of the big emerging technologies in relation to data especially is AI and machine learning. But there is an element of inherent bias that can sometimes sit within those programs. And, you, like your colleague's example of, well, the data's wrong, but the story tells a different story. How important, and, have you come across in your experience examples of when sometimes there's an issue with the algorithm and it's not anyone's fault, but because people bring their biases when they're developing these solutions, it can tell possibly the wrong story with the data.
Absolutely, that does happen, and it's an important problem with AI and machine learning. So back in the day, 20 years ago, when I was learning about machine learning, we weren't thinking about biases. We were simply looking at how do we find the best fit using a certain machine learning algorithm applied to certain data. And we would take it for granted, even if it's a black box. So now things have changed. Nobody wants a black box anymore. People want to understand, and rightly so. So it's a really important challenge. There are a lot of examples that are sort of publicly discussed of bias in algorithms. So the AI is actually, the algorithms are quite sophisticated, and they'll pick up on the biases that are already embedded in our data, right? So if the biases affected how we cared for a certain population, certain ethnic groups, or women, those biases will be there for the algorithm to learn from, and it will learn not to offer the right treatment, for example, for a certain ethnic minority. So it's not the algorithm's fault, but the designer should be mindful of that. It can get tricky. How do you strip that out from the historical data? There are techniques available now, and many that are being developed. But at a minimum, testing the algorithm on different populations before it's released out is a really important step. We call it a model sheet that will answer some of these questions that you're asking. How does the model perform in an ethnic minority? How does it perform older patients or younger patients? How does it perform in women? So if you're getting radically different answers that don't match clinical evidence, that should be a flag that the algorithm wasn't designed properly or is picking up on noise or some of the inherent biases. So trust in AI is going to be critically important.
And I think you hit the nail on the head there because you talked about the algorithm is only as good as the data it's learning from. And I think that's something that, I imagine all jurisdictions and all different health services struggle with, because there is so much data that we have at our fingertips, and some of it we can't make sense of. But if it's all just fed into a particular algorithm, then it's not going to be valuable. So maybe from your experience, obviously you've told us stories from right back when you started doing this. What have you done, or what are some of the opportunities you've seen to help people ensure that their data is accurate and is usable to tell a meaningful story versus something that, has been, say, incorrectly coded or even just not entered in at all?
Yeah. The challenge is that I don't think there's any such thing as accurate data. I think we have to start with that assumption that all data are imperfect. Now, then the question is, how imperfect is it? Is it too imperfect to be used for the problem that you have in mind? And that takes some skill and expertise and clinical input as well. But if we say, okay, this is good enough, and how we'll use the algorithm is as a screening tool, right? Not to say this person has cancer or diabetes, but to say we should do an additional test on this patient to confirm, as we do with a lot of other medical tests. So I think that's probably the right approach given the state of the art in both data, especially healthcare data. Now, if we were a bank and it was all about dollars and cents, it would be much easier to do this. But healthcare data just inherently are murky. So we have to accept that. I don't think we should use that as a reason to not apply some of the newer technologies. And the other thing I would add is that the scope of AI is, of course, much broader than simply building algorithms that predict something. What I'm most excited about in use of AI is around images. So AI can be quite good at reading an image. The image could be a chest X-ray, or it could be back of the eye, the retina. The best example that excites me the most is AI that's embedded in retinal cameras. So you can actually buy a small camera that fits in your coat pocket, works with a mobile phone, and you can use that to take the image of the back of the eye of, say, a diabetic. The camera and the software is smart enough to say, hey, this is not a good quality image. Take it again. And it will say, okay, this is an acceptable quality image now. So now AI is helping someone who could actually be a lay member of the community out in a rural area take these images. And once they've taken a good quality image, AI is smart enough to read the image and say, I see retinopathy here. There's retinal disease in this image. Or this is perfectly normal. There's a term called inference at the edge. It means you can run the algorithm right on the telephone or in the camera. It doesn't have to go to the cloud, doesn't have to go to the server. So private data doesn't have to leave the device, but you can still make a diagnosis. So if you imagine what would normally happen for this patient, I would put an order in, give you the US example, I would put an order in the electronic health record, a referral to a specialist. Patient will make an appointment, go see the specialist, they'll put eye drops, take the image, patient has to sit there a couple of hours because they can't see straight. Somebody has to pick them up. And then the ophthalmologist will read the image amongst a lot of other images. They'll send the record back to me. It will hopefully show up in the electronic health record. I'll look at that. A month may have gone by, or 2 months if the patient simply doesn't have time. So we've taken this whole value stream from intent to order to a diagnosis, shrunk it all in a single device, and in minutes rather than days and months. To me, that's the power of AI. Those are the kind of problems we should be looking at to solve with AI. The algorithms, I can make a perfectly good model using logistic regression. People don't get excited about it unless you throw in deep learning. But you can get the same information, sometimes simply from a table of data. So anyway, that's my other soapbox that I sometimes get on top of. Simply because you have data doesn't mean you should apply AI or machine learning to it.
And that is an incredible story. Like just there from the 2 months to the 2 minutes and that's a tangible outcome, and probably at low cost too, because,
Exactly.
you've cut the number of clinicians and, the points of care and the confusion and the time. And there's so much value there. That's an incredible story. So, Raj, I just wanted to talk to you a little bit about one of the case studies we read up about, where you talked about one of your patients. And going back to the point there about AI, in the future, do you see medicine and, healthcare in general leaning towards a kind of patient-centered care with the clinician up front and center? Or do you see it more AI-based, or do you really see it as a mixture of both? Is it fully automated? Is it, completely humanistic? Or is it somewhere in the middle?
I think it may be someplace in the middle, but skewed to the right. I think there are some things that AI can and should replace clinicians for. I shouldn't have to search through the electronic health record to find all diabetics that I should follow up on, or to gain insights on what happens with a certain type of patient when I prescribe a certain medication, right? AI is much better at doing those kind of things, and it should do that. A lot of the radiology workflows, AI is much better at doing that than humans are. So AI, I think, can and should replace a lot of those things. But when it comes to, back to the example, that was one of my patients who really taught me a lot. It's really important that we don't disrupt the relationship and the trust between clinician and their patients that they're trying to take care of. So AI, I think, can augment that. It can be behind me, looking at what I'm putting in the record, giving me insights that I have the freedom to choose or to reject those ideas. I think AI algorithms can risk stratify populations. So there's great use case in population health and public health for AI. And I can give maybe a quick example, which also happens to be another one of my soapboxes. At least in the US, we spend a lot of time and a lot of money on sick care. The whole health system is designed around sick care, which is really important. When people are sick, we have to take care of them. But we're not spending enough time thinking about what I call the reservoir, is the source for future chronic conditions and high costs. So it's things like obesity, things like depression, things like fatty liver or high lipids. So these are not diseases per se, but this person isn't healthy. They're not sick, but they're not healthy. Or maybe they're both. Maybe they're healthy and sick. And you don't know until you look to see which state are they in. And then working on these problems, this is what I'm spending a lot of my time doing now. I call it the cardiometabolic cluster. So lipids, body mass index, blood pressure, blood sugars, really simple markers that can help us risk stratify patients much better than simply looking at numbers and using a cutoff that if BMI is about this, then do this. So I've personally been building some of these models on supervised learning, so I can stratify the patients into different clusters. And I know somebody who's in cluster 1 has a much higher likelihood of developing heart disease or diabetes. So now, how do you support these patients? What they need help with is not medications, not clinics. They need help with behavior change, lifestyle modification, healthy eating, right? So where in our system are we spending time and money on those things? There's not even a payment model for a lot of these conditions, at least in the US.
And I think what you're talking about there is precision medicine, like looking at at the patient as a whole and all the markers and not just the disease markers.
Right. Exactly. That's a nice way to sum it up. It's a whole person care, their physical health, their mental health. It's an artificial distinction between the two. So for truly person, patient, human centered, we would look at this holistically, look at these markers together, and then apply some precision to our approach. There's not a one size fits all when it comes to these type of things. Every person is different. Their context, their culture, their background, the ethnicities, everything is different. So for a human clinician to sort all of that out is tricky, is hard. So this is where tools like AI can help us do better.
Yeah, I think that's an excellent point, because I think, clinicians are always time poor, and they want to do more, but sometimes they just don't have the time. And I think what you're talking about there is, automating some things so that they have more time to maybe do the analysis or maybe look at the data and understand, but they need help with that. And I think you're right. Like, AI is probably a really good way to look at some of those things and make some of that, do some of that analysis, so that the human can then do the deeper analysis. That's, yeah. Well, I don't think we have any more questions. I think we've probably got quite a lot there. But is there anything you wanted to add, Raj? Any final thoughts or words for our audience in particular?
I think we've touched on the important things. I'm often asked in my travels, and spent a lot of time traveling in Australia and New Zealand, seeing a lot of my colleagues and learning, which, by the way, I miss a lot. So I'm waiting for travel to reopen. I think all of us are. People ask a question, so, okay, this is all great and wonderful. Where do we start?
Yeah.
Right?
It's a good question.
Right? So, and I think, at least in the context that we've been talking in, I would say start with a problem. Data AIs often are solutions looking for a problem. I think we have to flip that and think, well, what are the key problems we're trying to solve? If it's the reservoir chronic condition problem we're trying to solve, if it's the hospital infection problems or the cost problem or remote care problem, what is the problem? Let's pick a problem that we want to solve, and let's huddle and figure out what would the work look like. And I think of work as jobs to be done in time and space. So think about, to solve the chronic care problem, what are the jobs to be done? When do they need to be done? And by whom? And I would add, by what? Because AI may be, or the robot may be the what. So it's not I'm not answering my question specifically saying, work on this. But I say, start with a problem. Don't start with AI or technology. It seems like simple suggestion, but it makes a difference to frame the work correctly. People get a lot more done if they start with a problem that we care about. So what are the problems we care about? And let's figure out, what would the future of work look like?
I think that is an excellent answer, and I think you're spot on there. A lot of times we just try to fit technology into places without knowing why we want to fit it in there. And I think saying, what is the problem, is very powerful. I think you're absolutely spot on there. That's incredible. Thank you so much for being here, Raj. I really appreciate it. No, it's a different time zone. I don't even know what time it is there for you, but I imagine it's
at night.
Oh, okay. Yeah, I imagine it's been a very long day, but thank you so much it was really interesting and great to hear your stories. Thank you so much for sharing them. I think there's some really interesting things we can take away and look at from a New South Wales health perspective. So thank you so much. It's been a pleasure.
No, thank you. Pleasure is mine. It's so wonderful I enjoyed the conversation.
So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you're on right now.